The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, with another issue of the Genuine Article, and I'm here with Paul Armstrong, who's professor of medicine and cardiology at the University of Alberta, and he's been the primary author of a very interesting paper in JACC that deals with the value of the Q wave on the electrocardiogram in timing the onset of a myocardial infarction. Paul, what led you to study this question?
Tony, like many of us, I've been concerned that the ascertainment of time, which we get from our patients, is often imprecise, ambiguous, and sometimes entirely absent. So we asked the question, is there another way that we can actually elucidate this? And we thought that the electrocardiogram, which is, after all, an online bioassay of the evolution of an infarct, might be helpful.
Well, it's so logical. Very few patients get chest pain and say, oh my goodness, what time is it? And so the Q wave makes a lot of sense. How did you go about determining whether it really was of value?
So what we did, and we were fortunate to have ascertainment of electrocardiograms in a large population that underwent primary PCI in a clinical trial, is we looked simply at the baseline electrocardiogram when they came in, and the randomization window was 6 hours. So according to guidelines, we divided patients according to 0 to 3 and 3 to 6, which is often the way we think about this. We did that. We looked at the time, and then we looked at the ST resolution about 30 minutes after the PCI, which was done in a very timely way. These patients were well treated. And we had 90-day mortality, and we had also the composite, which is often in these trials useful, of death, shock, and heart failure. And so what we did then was we lined up the information on time, the information on whether there was a Q wave in patients without a prior infarct and the distribution of that ST elevation, and then we went to work to sort it out.
And the answer is?
And the answer is that patients who present with a Q wave in the ST elevation distribution, which is a little over half of our patients in this instance, had worse ST resolution. They didn't reperfuse as well after their primary PCI. They had bigger infarcts, and they did worse in terms of their 90-day mortality and outcome. Moreover, when we examined the impact of time as opposed to the Q wave proved to be superior, believe it or not, over time from symptom onset, which was the most striking finding after we did the adjustments that you always do in these trials. And I think your readers may be interested in looking at the figure in the manuscript that shows nicely that the Q wave seems to be superior. So we think that's potentially quite attractive as we look to the future.
Yeah, there's no question, Paul, that it makes good logic that the Q wave on the electrocardiogram ought to be of some real value in determining the amount of damage that's already occurred. How are we going to utilize this information when we treat our patients?
Well, I think that it should give us pause when we're sitting in an emergency room or an ambulance or an electrocardiogram at home in terms of what patients might benefit from what reperfusion strategy and where they should go. Clearly, if there's a Q wave already present, irrespective of the time, it looks as though that infarct is well on its way, and that patient might best be served by primary PCI and is at higher risk. We also think, in relationship to the Guidelines Committee should look at this as a possible addition to time from symptom onset, which at the moment is the central preoccupation. We'd like to try to add value to that. And finally, we think as we design future trials to look at these patients, that this should be taken into account in the so-called enrichment strategy of what patients to treat with what.
Well, it was really encouraging when we reviewed the manuscript to see that a very available clinical marker, the simple electrocardiogram, a Q wave on electrocardiogram, could be of value in helping clinicians decide how best to manage individual patients. We'll look forward to see if perhaps we can nail down even some more specific recommendations. Thanks for being with us.
Thank you.